Rod needs to button his shirt up more. He needs to wear a chain. Well, good morning, everybody. My name is Jens Chapman, and it is 6:30 in the morning here in the Pacific Coast time zone. And my name is Jens Chapman, and welcome to this edition of STED Talk, Spine Technology Education, and the multidimensional D for Discovery, Debate, Discourse. And today, the D stands for Discovery. It's a great honor to have Dr. Raj Sakhrekar here, and I believe he's in Perth in Western Australia. Is that right, Raj?
Yeah, that's right, Professor Chapman.
Fantastic to have you. What's the time and the date there? You're in the future, right? So tell us what the time, and I think it's going to be February 19. Is that correct?
It's February 18 still. It's 10:30 p.m. It will be in 1.5 hours. It will be February 17. So it's 13 hours, 14 hours ahead of your time.
And we don't have your picture here live when Ben can switch it. I want to thank Ben and Corey for their work. Great to hear your voice. Fantastic to have you on board with our thing, with our enterprise here. And this is a particularly cool occasion. I'll introduce Dr. Sakhrekar a little bit more in a second, but he's a globally trained spine surgeon, and he's a member of that new generation that wears gangster glasses and is really cool on social media. He's all over, and he is a very, very intriguing colleague in international conferences. He's a presence, and his opinion is much sought after. And we're going to talk a little bit about how we as spine surgeons can use social media to try to influence public health care. So we're going to wait here. I still don't see a live picture. I'm going to switch to the case presentations once I see a live picture. Is Raj? Make sure it's him. There he is.
Yeah.
That nicely freshly pressed coat. So good night, right?
Yeah, good to see you, Professor Chapman.
Yeah, but I was luring you with by saying good day, right?
It's a good day.
Good day. This is a good day. Hey, so great to see you here. So tell us a little bit about what the topic of your talk will be today, and then we'll show you a couple of cases that our fellows have put together. So what's the inspiration for your topic today?
So it's very important at this moment of time, need of the hour. As a spine surgeons, we don't kind of advocate ourselves to inform and encourage each other to spread and more awareness about spine surgery, the success of spine surgery. And as we know, there is misinformation spreads like a wildfire, and the current information have online or any platform on social media or Instagram or TikTok or Facebook is really low in terms of educational content, in terms of quality of the scientific evidence. And that really pains me a lot to see that our population being part of various societies and organizations, and being lucky to work in 4 or 5 continents across the globe over the last 10 years, the misinformation is very like spread a lot, and it kind of brings disrepute to the spine surgery. So when we started with the Ortho TV, Spine TV, and along with when I was a member of the social media team of the Scoliosis Society, as well as the Spine, we thought that we should, as spine surgeons, come together and create more and more awareness, not just for the physician to physician education, but also for the general population, that will create a positive tone about spine surgery, that will create more awareness and overall bring more knowledge, more evidence-based practices in for everyone, for just not just physicians, but also for general population. So that's the idea, and my whole topic will be focused on how we can come together and bring this awareness together for everyone.
Fantastic intro, and in that spirit, we have, I think, 4 cases that all go into the public health domain of spine surgery, where we as spine surgeons can possibly influence public opinion and knowledge base. All those are challenging cases, Raj, but none of those are curveballs, okay? So there are no tricks in there. You're not gonna look bad about something. This is just what we face literally on a daily basis. And for starters, we have one of our 4 great fellows are here right now, Mohammed El Houshemi, and and he is from the Lebanon originally, and he's going to show just one of the usual cases that come across our doorstep. So there's no secrets there. Raj, great to have you here. We'll look for your comments. Mohammed.
Thanks.
Okay. Morning, everybody. Good evening from your side. We'll start with this case. This is a 61-year-old male. You see the list: diabetes, hypertension, liver cirrhosis, alcohol abuse, morbid obesity, all public health problems, no significant past surgical history. He presented initially with altered sensorium, some back pain, and severe anemia to an outside hospital. They did an initial workup. His hemoglobin was 4.2. He had severe esophagitis, GI bleeding. So he went into emergency endoscopic control of bleed. And the imaging of his spine, of his CT chest showed all this finding. So we have massive degeneration along C6, C7 with air bubbles filling the whole spinal canal. This is the lumbar spine also here shown, and this is the thoracic spine. So further workup was done. This is the MRI of the cervical spine. On STIR, we see high signal. These like 6, 7 cervical vertebra, and this is on T2. You cannot differentiate between the white signal here versus the CSF. This is actually epidural abscess. Again, here on the thoracic spine, this is whole epidural abscess pushing the spinal cord all the way back, spanning from the cervical spine down to the lumbar area around L4, L5. This is again a video showing these MRI findings. So the patient was transferred to our care after he was stabilized for continuity of care. He presented intubated, and this is his physical exam. He was like grossly weak, 3/5, but this exam is not very adequate. He was intubated and sedated at the time. So I gave him a 3/5. He was moving to painful stimulation with some sensation. So again, 61, diabetes, morbid obesity, hollow cord abscess, motor power at least 3/5, intubated. What do you think the next step?
Raj, way to start, right? Thank you, Mohammed. This is an easy one for us starters, but
Yeah.
I consider the spine the filter of life, kind of, both musculoskeletally in terms of its very large exposed marrow surface, the more passive cartilage of the discs, and then the neural elements. And so when we have disasters like decade-long alcohol abuse, lack of exercise, etc., diabetes, things happen. I'm not sure in your global travels how far spread these kind of just disasters are. Is this something that you see around the world? Is this just particularly bad here in the North American arena? What are your global perspectives on these kind of disasters?
Yeah, so like this kind of scenarios are very, very common in North America, where patients have a lot of issues with the abusive as well as narcotics as well as IV drug users, and this kind of abscesses are very fairly commonly seen in North America. Very few in Australia too, but the in subcontinent, Indian subcontinent or Asia, these kind of scenarios are very less. They have different kind of infective disease called tubercular there. But as I said, these kind of scenarios are very common in North America. Regarding this case with the hollow cord abscess, various kind of there is a lot of differences in geographical distribution as well as treatment plans. Considering the weakness, most of the institutions 3+ weakness, and with such a general disability and morbidity, they try to be on less and less aggressive side. What I saw a few institutions doing, interventional radiologists, they just if there is hollow cord abscess, they just do kind of epidural cathetering, and if the abscess is more of liquefied and not like caseous or necrotic or fibrous, they try to drain it and send it for samples and cultures and things, and start the broad spectrum antibiotics until the culture comes. Once the cultures come, they give the more specific antibiotics, or whatever the antifungals or whatever the management is there. And these are the cases where we not to fix from C2 to sacrum or C1 to sacrum, because even if the hollow cord abscess is there, deficit is there, these are the cases we try to go less and less aggressive, get the more diagnosis first, more precise diagnosis, and treat it with least intervention.
So where would you start here? Thoracic spine, or would you make a punctate approach in the cervical spine, in the thoracic spine, the lumbar spine? How many incisions roughly would you make, and where would you place your emphasis?
Yeah, so it's very interesting. First, we'll see on the imaging where it looks like more of a fluid, and I've seen some cases where they put like caudal epidural catheter passing through the canal, through the caudal epidural region, through the sacrum, and try to aspirate the lesion if it's in lumbar region, like past the cannula. And I was in Korea, and they used to do this very advanced technique. Even the catheters, it's quite like SELD, they have the cameras inbuilt in it, and with the like tiny incision of less than 5 mm, they pass the catheter and aspirate the infective lesion as infective pus and send it for sample. So that's kind of, I feel, a new thing, and the future will go towards that kind of scenarios where hollow cord abscess is involved. Wherever there is more liquefied lesion, we will go as per that. But one of my favorite thing is to pass the catheter through the transsacral route, kind of the way we use for the caudal epidural, and take the abscess or the lesion.
All right, so show us what we did and why we did what we did.
So what we did was like skip hemilaminectomies, starting at the upper. I was not there. Dr. Mark was in the case, but I am just stating what's happened. So the upper thoracic, we started with the upper thoracic, T1, T2, T3 skip lamis, right and left. Luckily, the abscess was like newly formed. Frank pus came out. So two lamis were done, the upper thoracic, 3 upper thoracic, and down in the lumbar area. These are the X-rays, and a ventricular catheter was passed. I think there was planning to go into the thoracic spine, but he was bleeding like hell because of his like liver issue and his INR. He did fine after the procedure. He was extubated. Actually, his motor power was like nearly normal. And this is on follow-up. So this was done like around 20 days post follow-up. The abscess resolved all the way except for this mid-thoracic T67, where there was like a clear area, loculated area here around T67. So we took him back to the OR, and we did like T67 hemilami. We went a little bit on the transpedicular side to evacuate that. We cleaned the whole area. We cleaned a little bit the disc space. The pus was not very frank this time. It was like more on a phlegmon side. So we're not able to aspirate a lot of stuff. Patient did fine. Also, as I mentioned, no massive neurological deficits were present to begin with. He was transferred back to floor and for continuity of antibiotic therapy, and then he was discharged.
So if you go back to a thoracic secondary lesion, I'll ask Dr. Kramer. So there are various causes for epidural abscesses. We've never totally figured out why or what the solitary major causes, but one known cause is discitis, and then this serves like a hydraulic effect. Whenever the patient loads and unloads, basically an inflammatory response plus fluid is created and then creates this discitis effect. When do you decide to do a stabilizing surgery and a more aggressive resection of a discitis lesion, which in this case may have actually driven that epidural abscess for starters?
That's a good question. I know, in this case, I think that the challenge in this particular case is that, he was very unhealthy. I think he had some alcoholic-related platelet dysfunction. He had some cirrhosis. So at least on our initial approach, we actually planned to do additional skip lamies in the thoracic region as well. But just due to the very ferocious bleeding we experienced, we decided less was more initially. And just given how liquid the pus was, we felt we had actually a pretty good evacuation, at least with we had 2 ventriculostomy catheters above and below. We were able to irrigate kind of up and down and get clear fluid out. But we were aware that this T6-7 discitis was there. And maybe a mistake of mine to not re-image on a more, routine basis post-operatively, but we were definitely concerned that there could potentially be some residual infection there. But we figured, again, given his comorbidities, that at least at that time, less was more. In this case, I think you're right. I think there was residual infection in this disc space, and that kind of pushed out some additional infection locally in that area. In this case, we left the midline structure, so I felt like we, could get by doing a little bit more and wash out the disc space. If we felt that we had to go bilaterally, I felt like, then, instrumentation would probably make sense.
So Raj, you've again been a globally trained spine surgeon. We're getting as a society around the world actually older and sicker, and our administrators and our healthcare systems can't afford healthcare very well, for starters. So how do you kind of see these increasing disasters that we see evolving? Is there a healthcare system that kind of deals well with people who are this sick? Here it's kind of a very difficult balancing act, because administrators don't want to take care of these patients, but they show up and they measure our length of stay, and then you have a patient where you're desperately trying to survive and help the patient. So where are healthcare systems that kind of deal well with patients? What would the ideal world look like to try to not end up in these difficult situations?
Yeah, that's really important question in this scenario. The lifespan of the human beings have been increased as per the last understanding. It's increased from 65 to 75. Now it's more and more increasing. What my understanding, where most of the big institutes, what they're doing, as we are getting older, we are getting more sicker, and new pathologies are coming, and the number of surgeries we need to do, they are also increasing. But with that, most of the centers are kind of differentiating themselves, like with a bigger rehabilitation unit. So if the patient needs a surgery, or if consider this patient, he will come in just for the procedure, where the surgical unit or surgical care is available. He will have that surgery, and he will be shifted to the rehab unit, where he will get the utmost and best rehabilitation, and go back to being his best, or being in healthy. Consuming the bed, consuming the cost in the surgical hospital, in the surgical unit, might not be the right way. The surgical unit, the surgical theaters or surgical hospital need to be more productive in terms of the surgical care they can provide, and the rehab teams, the rehab hospitals need to provide the best rehab so that they can go back to their life. So to look forward to the way of future, we should separate more of a surgical unit versus a rehab unit, with little bit of more care from geriatric unit, rehabilitation unit. I mean, rehab means all non-surgical branches involved in it, and I feel that's the way forward.
Mohammed, what would you do differently now that you're going to be an attending starting in next summer? So what would you do differently in this case?
I would do the same thing, but we were more aggressive on the midline compared to what I'm learning here. So we would do like skip full lamis and try to clean it up, thoracic and lumbar, and follow up on the kyphosis and the progression of the patient.
So no much different. How can we get through to patients? I mean, this sounds very obvious. I mean, don't allow yourself to get too big, control your diabetes, enhance your muscles. Raj, have you seen any success stories in terms of getting through to the public for what's pretty basic self-care? Can we reach the target population through social media, in other words?
Well, again, we get patients from like countryside. We being currently Royal Per, the level 1 tertiary center. Other institutes I worked, again, tertiary center. But it's very, very difficult for the people from the countryside or remote areas to really come to the tertiary care. A lot of things are there, like GP referrals. Those who come up in emergency, they also get a little bit of triaging, and there is a little bit of waiting time everywhere. So what I understand is we need to create more and more awareness about these conditions, that okay, this is a spinal condition, these are the symptoms, this can happen if you present with this condition. Come and report to your general physician, come and report to the emergency. That eventually improves the results in terms of, we always call time is spine, and that's the way to reduce the duration of wait and improve the results by creating more awareness about it, that these are the symptoms, these are the things you should know about, and these are the things you should do about yourself by presenting yourself to the emergency department or the nearest physician or nearest care hospital.
Great points. And Dr. Nishant has pointed out that he uses endoscopy at multiple levels to try to get multi-point laminotomies, and then does a suction irrigation. So I think that's, again, a potentially appealing future option. Thank you, Dr. El-Hashimi. We have next Mohsen Karami. He came to us originally from Tehran and from Iran, and he has also been to Canada and trained as a pediatric orthopedic surgeon, now does spine surgery. So going right along the sick people theme, tell us about this. This is an actual fellow surgeon, I believe, right?
Yeah.
Okay.
So good morning. This is a case probably it's good to discuss about, social media and, other perspectives. So that was a kind of male patient, 50-year-old. He came to us like years ago because of the severe back pain, like fever, sepsis, and unable to walk because of the weakness of the lower extremities. So in terms of past history, he had severe back pain and sweats 2 months before come to us. While he was traveling overseas, and there they found out that he had kind of this herniation with probably UTI. So they did endoscopic surgery for L3, L4 discectomy, and then after a while, like 2 weeks, he developed bilateral radiculopathy, and then came back to the US, and MRI done again. It showed that there is still there L3, L4 disc herniation. And then he was planned to do another discectomy using tubular approach, and they found out that there is pus from the disc material, and they started IV ceftriaxone. So basically, he came to us after 3 weeks of about a month after that last surgery because of the sepsis, weakness of the legs, and severe back pain. So past medical history, he was had history like bicuspid aortic valve with regurgitation, and he socially he was a surgeon and not a smoker, very sportive, no kind of diabetes or other red flags for the spinal infection. In terms of physical exam, when he was with us, there was severe weakness, all lower extremities, muscle strengths were 4 out of 5. Right side sensory deficit, no saddle anesthesia or codacoinous symptoms, And his YBC was about 17,000 CRP, and ESR was very high. So this is the X-ray and imaging that we have in his chart. So that was a month ago on the left, and at the time of admission to our hospital on the right side, you see the difference. So a month before, there was L3, L4 disc narrowing and retrolisthesis. And then a month after, when he came to us, there was the same with more, deformity with scoliosis and retrolisthesis of L3 over L4. And this is the CT scan 1 month before and a month when he came to us. So you see that L3, L4 disc, destruction with osteolysis of the L3, L4 end plates, and retrolisthesis with spinal stenosis at the same level. And this is the MRI, the last one. It showed that there is epidural abscess, intradiscal abscess as well, and the facet joints were also involved. So he was 54-year-old. He had sepsis, very high, YBC. SISS score, the spinal stability in spinal stenosis score was 14, 15. This is the highest, score, which indicated unstable spine. So obviously we don't talk about the plan. So if you have any idea about the management.
So, Raj, this is one of those things that's very perplexing. This is in principle, very healthy surgical colleague, athletic, very, very active person, team doctor. He's a surgeon. He's had a little bit of a heart problem, and he has a tubular discectomy and then has this disaster. So there are multiple tangents to this, but one of the questions was always, supposedly less invasive spine surgeries, such as tubular surgeries or endoscopic surgeries, have a lower infection rate than, quote, open surgeries, whatever open means. Is that really true?
Well, again, when we talk about the infection reasons vary because of the many reasons, as we all know. First, the patient factors. If the patient is healthy, patient doesn't have much comorbidities, patient is non-diabetic, non-hypertensive, no cardiac conditions. The healthy patient with the good muscle, good tone, good nutrition, these are the factors. Second, the surgical factors, depending on the time of the duration of the surgery, depending on the technique of the surgery, depend on the how much posterior structures or anatomical structures you are going to disrupt during the surgery, how much anatomical loss we are giving due to the surgery. These are the surgical technique approach related factors. And third, hospital acquired infection rates or institutional infection rates, all these factors. So I feel these three important factors, considering first the patient factors, the surgical approach factors, and the institution factors. These three factors plays key role considering the infection rates of any case.
So the second question is, when we see these infections, we actually have the site score. I'm going to put that into the chat that we developed here because we have so many patients who come to us with infections. There's a de novo, in this case, is a post-surgical infection. But obviously the question is, should we do a more aggressive surgery now? Is a washout enough? We saw a case of Dr. Kramer's in the thoracic spine that seemed to do okay with a repeat washout. I probably would have honestly done a fusion surgery on that patient, reconstruction with debridement. But in your global experience, starting with India maybe, these can heal by themselves. Is that right? Or do we, when do we start thinking about having to do a reconstructive surgery?
So when there is development of the mechanical instability, or there is one of my mentors used to say, infection will burn in the fire of stability. Infection will burn in the fire of fusion. That's the dictum, like very few people follow it. But I also believe this same principle that the infection will burn in the fire of fusion and the stability. So if particularly this case, we'll definitely try to stabilize it, considering the significant mechanical instability this patient has. Will anterior to SWAS or anterior surgery or olive surgery in this L3-4 scenarios sounds pretty good. There will be less destruction of the posterior structures. There will be destruction of the spinous ligaments, spinous process, multifidus, all this. If you go by ATP, just clean it out through the ATP approach. Put nice bone graft, either a cage, or sometimes in the Indian scenarios, we put a lot of iliac bone grafts, which has shown like good amount of fusion and early fusion and good stability. Sometimes if you put a metal in it, there is again chance of biofilm covering of the cage or the metal and the repeat or recurrence of the infection. So we use a lot of bone grafts in subcontinent to give the stability and just percutaneously fix posteriorly. So that would be my plan in the scenarios where the infection is there. Do the anterior approach, debride, wash out, put the big iliac crest chunk there, and fix it posteriorly percutaneously.
So how many levels would you fuse? This is, again, until his discectomy, a practicing surgeon who liked to be very active, played sports, again, a team doctor. So how many levels would you sacrifice here, just concretely?
Yeah, so if I will be able to put a good amount of bone graft at just L3-4 level, and if I feel on single level, just bone graft at L3-4 and percutaneously, if I be able to reduce that, I should be able to be fine just with one level. But if I feel it's still unstable, might go like 2 levels up, 2 levels below the L3-4 disc. But try to be as minimum as possible. There is great amount of literature published in subcontinent as well as across. Infection will heal. It's not a trauma scenario. It's not a scenario where there is a loss of structures. These structures heal very well, and I will try to be as minimum as possible. If possible, if I get good purchase, just interbody fusion at L3-4 and screws in L3 and L4. If I am not happy with the hold and anchor and purchase, maybe just two level up, 2 level below.
Yeah, so yeah, we felt that L4 was damaged. Mohsen, what do we do, and what is your thought on reviewing this case?
Yeah, so because the patient was very unstable regarding his condition, endocarditis and severe sepsis, we started like for the management, we did like damage control. So basically we did like L2 to L5, the laminectomy and the removal of the abscess and flame. And then, so we try to reduce the L3, L4, malalignment and put a kind of bone cement, antibiotic bone cement there. And then we did like PSIF L2 to L5. So the patient was doing much better, fever, health condition got much better. And then after about 3 months, when the set rate and everything got better, so we removed those bone cements and we did like at 3 months, remove those and then did IDOs to make it more stable and correction for the deformity. So this is the X-ray after the second surgery. We put like we did like 2 IDOs and asymmetric IDOs and put 2 cages there because we had to remove the bone cements from there.
So, yeah, so this patient was super sick in the beginning, and that pedicle on the one side, on the right side of L4 was basically completely eroded. So we shared the wish to minimize fusion, but we felt that we absolutely had to go to L5. And we like antibiotic cement here. It obviously has a limited lifespan of actually eluting antibiotics. Are antibiotic impregnated cement implants something that you've used? Have you run across it in other countries?
So stimulant is have been used, and it shows a little bit of early results, but I'm not sure about the literature where the placebo versus stimulant are equally effective or not. What works, as per my understanding, is good debridement, where you could debride more, very clean, thorough washout, and make it stable. That should be the ideal goal rather than putting stimulant or something like that. So that's my thought process.
So what do you think of our approach there? So this patient was very sick, actually. He was cachectic and actually fulminantly sick when we did this index surgery. So we we differentiate the surgery into two. We did a debridement stabilization, and then as a second stage, we did the reconstruction. Is that a sensible approach, or could we have done this as a single stage?
No, this is really sensible approach. Our aim is always to do minimal in such tricky situations, reduce the bacterial load, reduce the chances of patient going in septicemia. So what you did is like phenomenal. Is with the stimulant, it reduced the chances of uh, full growth of the abscess growth, as well as the spread of the infection, as well as posterior stability gave kind of, as I said, infection will burn in the fire of stability. So that was really good approach. And as we said, stimulant might kind of get absorbed, and it will be we'll lose it over the period of time. So second stage stability is like a standard approach. We still follow that approach, but we'll trying to do as minimum as possible currently.
So, Mohsen, the patient settled kind of compared to my initial reconstruction with PMA cement, and then we did a unilateral kind of an attempt at resurrecting the right sided column a little bit more. I'm not sure that this is particularly perfect. He settled a little bit, but he actually healed. He's several years out now. So your thoughts, how would you have approached this? Could we have avoided this settling on the spine and the coronal plane?
Yeah, so basically, according to those, scoring system, if there is the scoring is very low, like less than 10, we can, opt non-surgical approach. For this case, the non-surgical approach was done, but if they done like scoring, and because at the beginning he had like this collapse and scoliosis, so that means that the spine was unstable. So you should have done like, better approach if there's any kind of involvement of posterior and anterior columns when there is like a spinal infection. So because of this, the spine was unstable, there was deformity and, destruction of the disc and end plates. So we have to make it stable and remove all, the dead tissue from there. This is the basic treatment for those kind of spinal infection. But if there is no kind of instability, there is no neurological symptoms, there is no mechanical pain, we can choose like non-surgical treatment. But this case, obviously, he has, all positive, criteria for surgical approach. And in terms of, bone graft, so probably BMP is a better option because it's very good in terms of, when there is infection, we can use BMP. And because of the inflammation of BMP, it improved the, defense against the infection. And then the other thing was deformity, and we approached the deformity very well there. And using that IDUs and, cages there, that improved the alignment a lot. And this is years ago after that surgery, the patient is still active in the OR doing surgeries, and the alignment is perfect.
Yeah, he went to surgical practice and returned to normal life after this infection calamity. We still don't know why he had this infection. I think that he had a urinary tract infection. But my one worry, and this was done at an outside hospital, so I don't want to cast any identifiers out into the public here, but one worry that I've seen is with tubular type surgeries, you have to have or work at an institution that's particularly meticulous at cleaning and really sterilizing after a successful debridement these endovascular tools, or these endoscopic tools. There's a specific cleaning regimen you have to fulfill, and if that doesn't happen, you can literally create problems. So I'm not sure on a large-scale population base if tubular and endoscopic surgeries truly have a lower infection rate, because while great institutions that publish these studies usually have a good algorithm, the larger landscape may look different. You have to be very, very facile at doing quality control. And some of our fellows who've gone into different hospitals around the country have reported that they're really unhappy with their cleaning regimens. So just one food for thought. Dr. Kramer, you're from Wisconsin originally, a neurosurgical colleague from Wisconsin. How would you have approached this situation? Any thoughts on how we could have done better in alignment? Again, this patient is back into a normal lifestyle. Obviously, we're holding our breath as to how long these discs above this fusion will last, but anything you would have done differently?
No, I think the approach is very good. I think, the second stage, beautiful reconstruction, I'm not sure. I think we probably would have tried to, do everything at the same time, that first stage. It'd be my suspicion. No, I think the approach is good. My only comment, I was looking at that last X-ray, it looks like that right hip, I'm not an orthopod myself, but that right hip does look like it's quite degenerated as well.
Yeah, no,
that contributes to some extent to his.
Yeah, so the left hip was damaged, as you can see, and he withstood a total hip replacement without getting infected. So he really seems to be clear. But we waited for 3 months for the staging. Yeah, so infections can happen all the time. Being critical about that and probably being a little bit more aggressive. I put into the chat again the site score, so you'll use the site score in the future because we published it. But as a decision-making tool, we found it to be very helpful in terms of assessing the magnitude and severity, like what Raj has talked about earlier. So let's go on for another case. Is Casey here? Yeah, Casey, let's take you up front. So Casey is going to switch to something different. Then we have one more case after that with myelopathy. Casey Spinelli is here from Michigan. He's a neurosurgical colleague, and he has a different dimension of a public health problem, and that is osteoporosis and aging.
Yes, good morning. Good morning, everyone. Dr. Chapman, thank you for the introduction. To those of you joining us online, my name is Casey Spinelli. I'm one of the neurosurgery spine fellows here coming from Michigan, but before that, I'm originally from New Orleans. I swear I have a case to present, but when I was making this presentation yesterday evening, I realized I had to include a very important slide for my city and our culture.
Yes.
So, as a native New Orleanian, I would be remiss if I didn't mention Happy Mardi Gras to those who celebrate. And if you don't, I'm sorry, because everywhere else, it's just Tuesday. And so these are some pictures of Mardi Gras and what we do on Fat Tuesday down in New Orleans. Here we were doing a 2 or 3 level revision TLIF, but it looks like they all had a great time down there yesterday. So
That's cool.
So my talk today, spoiler alert, the end is going to include a discussion on osteoporosis and the management of this in some specific populations. So we'll jump into it. So today we had an 84-year-old male present to clinic with a fairly common chief complaint of severe lower back pain, with pain and paresthesias radiating to the buttock and the anterior lateral thighs. This is a recurrent presentation. He had similar symptoms about 1 year ago, but now he has this new progressive weakness in both legs for about 2 months that he didn't have the first time with this presentation. So from his history, we know that he has prostate cancer, status post a radical prostatectomy. We also know he has osteoporosis. His pre-clinic DEXA examination was negative T-score of negative 2.9 at L3-4. He's managed on Prolia for the past about 1.5 years. And we'll talk more about that at the end of the presentation here. So before clinic for review, we have this DEXA scan and we have these plain radiographs of the lumbar spine that show cement augmentation at the, I think, L1 and L2 levels, as well as this L2 burst fracture with the cement augmentation there. So on physical examination, you note that forward flexion relieves his pain and extension is painful, and that he has generalized weakness in the bilateral lower extremities, especially with hip flexion, knee extension, and dorsiflexion at the ankle. He also has diminished deep tendon reflexes bilaterally. So we ordered urgent MRIs of the thoracic and lumbar spine, as well as CTs of the thoracic and lumbar spine, a TC99 study, LSO bracing, and a home-directed self-exercise regimen. and for him to come see us again in the clinic in a few weeks with these studies. So he returns, he goes out, he gets this imaging completed. When he comes back, he tells us that he can ride this stationary bike that we had recommended to him for about 30 minutes, but he could only stand and walk for about 10. So we see that discrepancy there. So on the imaging, you note that there's retropulsion of this now collapsed L2 vertebrae with moderate severe central stenosis there, as well as some post-stenotic arachnoiditis of those lumbar roots down below this level of stenosis. So at this first visit, we talked about a plan. We talked about surgery. We offered him two separate things. We had this discussion. We talked about laminotomies with placement of Coflex at the L1-2 and L2-3 levels, which we've been doing a fair amount of here. Versus we also talked about laminotomy infusion from the T12 to L3 levels. We talked about, typically we would maybe do a shorter segment for this. However, with his cement augmentation of the L1 vertebrae, it would be tough to anchor a screw there, and so we would anchor at the level above. So we presented him with this plan, and I think this was in the COVID timeline of things. And so lost to follow up for a few months. So he's seen again, and we discovered that he underwent a full lumbar laminotomy at an outside hospital with bilateral laminectomies and resection of the midline structures. And after this operation, his claudican symptoms improved some. This was complicated by pulmonary embolisms and infection. However, now this patient has severe mechanical radiculopathy and the inability to stand for more than 3 minutes when we see him again. So we obtained some updated imaging, which you can see here. He's acquired this 13 degrees of kyphosis of the lumbar spine, as well as this worsened severe bilateral foraminal stenosis at the L2-3 level. So I included a picture here. You can see that totally collapsed neuroforamina at the L2-3 level.
So the points are osteoporosis, first of all. I mean, how in the dickens are we still not in an algorithmic state of care and most importantly, prevention for osteoporosis? This is particularly frustrating. I don't know, Raj, how it is from your perspective, but for us, osteoporosis management should be at least much improved now by using large-scale kind of machine learning tools that identify at-risk patients and put them into a pathway where they at least do the basics of osteoporosis management. Why are we not better about this? And this is an opportunity for social media and us being active on social media to get the population at large motivated.
Yeah, so we're calling osteoporosis the new epidemic. Like it's even bigger than what we usually think the COVID or any other cancer or any other disease we think of. Osteoporosis is global and it's like epidemic. And we are failing to treat it. We keep saying the osteoporotic fractures every day in the clinic. If I see 10 patients of elderly in my clinic, definitely 6 or 7 will be osteoporotic, will be suffering from the symptoms of it. So as such, as a physician, we should have an algorithm to focus on non-surgical management of the osteoporosis first. If we treat it successfully non-surgically, the complications related with it, the fractures, the neurodeficit which comes as a part and parcel and sequelae of it, that will drastically reduce. So we should really need to focus on the pharmacological as well as the management, which involves strengthening of the bone, strengthening of the muscles, just basic physical exercises, taking calcium rich, vitamin D3 rich diet, taking regular calcium supplements, postmenopausal care in terms of management of the all hormonals. All these are very, very, very basic things. Just need to create more awareness. And like we know, there was a time smallpox was a pandemic and it eradicated half of the world. And we're hoping that if we create more awareness about this, the osteoporosis related issues will also we can eradicate in the future.
Now, more concretely, this is kind of a constellation of a burst fracture, and clearly a vertebral insufficiency type burst fracture. in a patient with secondary stenosis is a really big one. Are there any answers that you have? How would you approach this kind of a constellation of a lumbar or thoracolumbar junction burst fracture and neurology caused by stenosis? Is there a simpler answer than what we did in the end?
Well, to be honest, I didn't follow the case very detailed, this one. But what we see is if it's a burst fracture, if it's mechanically unstable, if there is a retropulsion of fragments, uh, we try to avoid to do the vertebroplasty at that place. Various centers try to decompress by various approaches, whether it's transversal, transpedicular, or anterior to psoas. Give it a good stability. Try to uh, give a construct which will uh, kind of indirectly decompress also and make it stable also. So all these things we'll consider in mind to treat this kind of burst fractures.
Casey, going to our final reconstruction. So this patient had a laminectomy done after kyphoplasties, and that didn't work out so well. This is, again, one of those 80-year-olds. We see them a lot. They are very active. They want to kind of move. They want to get around. We did the least invasive surgery I could conceive of. We did bilateral cages to do nerve root sparing surgery. He was not a candidate for a far lateral surgery. What are your thoughts on this construct, and how did it hold up?
So thoughts on this construct, I think it makes sense with our surgical plan. Actually have an article cited in the next slide here from the Journal of Neurosurgery discussing the management of these things and how in this patient population, this short segment fixation with cement or polymethyl methacrylate augmentation at the end levels as opposed to longer segment instrumentation is good. But with this patient, we would have had a difficult time anchoring into the level just above with this prior cement augmentation of that level. So to me, this surgical plan made sense. And the patient did really well. Notes from over a year follow-up visit, he's walking over a mile daily. So compared to that prior complaint of he couldn't stand for more than 3 minutes, I think even though this gentleman is older, it certainly helped him regain some quality of life. So to move on to this discussion here, kind of 3 points we thought we would talk about with this case, right? And that's the management of and we talked about these a little bit already, but maybe the management of burst fractures in general, and worsening instability after these bilateral wide laminectomies with resection of midline structures as opposed to approaches that spare the midline, which we talked about a bit. And then kind of what I just touched on, but the management of osteoporotic associated burst fractures in elderly patients with shorter segments, instrumentation with in-level cement augmentation as opposed to longer segment fixation. And then just this last topic, obviously, I try to educate ourselves on these different things as we go through our cases. And so the guideline is different for the management of osteoporosis in males with the history of prostate cancer rather than the postmenopausal female. If this was a postmenopausal female, she would have been offered an anabolic bone agent, but with this gentleman's history, he was on the medication which is considered first line for his osteoporosis after prostate cancer.
So as a young surgeon, Casey, would you accept an AI guideline that pops up in your EMR when you put in the variables of this patient, like prostate cancer, aging, osteoporotic fracture, T-score, yada, yada, yada? Would you accept that? Would you this is very cool what you put together here, but would you, as a young surgeon, accept that? Would you find that helpful?
So, I like this mantra of trust but verify. And so it's kind of, same thing maybe when the internet was coming out, right? And people are like, all right, go look this up in encyclopedia and then tell me what you think the right answer is, right? I think this is a super useful tool. This is a snippet from just a cursory search on open evidence. And so I believe it indexes like more major journals and things like this. And so it's helpful to see at first, but obviously have to do a little bit of verification here for these things.
So Raj, back to you. So the information is there. This is really cool what Casey did here. How can we popularize this? How can we reach the public better? How can we kind of make sure that the public is interested in what we're thinking and will actually act on it? How can our colleagues also be convinced to use this kind of evidence?
Yeah, so um, there are various techniques. I feel the best technique currently, as individual surgeons, we can do uh, is collaboration. We can collaborate with each other and spreading knowledge among the colleagues, followed by if person A is having good knowledge and he wants to spread this knowledge with with the help of social media, he can spread it to about his followers. But if he collaborate to 5 other people, then that information will spread 5 times, even 10 times. If the same information, if I go and present on any society podium, that will spread again to the big uh, general physicians and the practitioners. But to spread to the general population, I feel the online education is very well retained, very well seen, and it spreads globally and very quickly. It's real time, and there is no cost involved. I'm talking to you sitting in Australia, and my viewers, your viewers, are seeing it across the globe. So I feel social media is the best way to kind of create this awareness. It's a simple message. What he told is it's a very simple message, and all it needs to be spread very well because it's evidence based. That's all I feel personally.
Okay, last but not least, we have Haggai for our final 5 minutes. Thank you, Casey. Great case, great discussion also. And Haggai Amsterkhan is from Israel, and he has a patient with myelopathy. And this is just a very quick see it and recommend treatment. And I think the treatment is not completed yet. It's a more recent case. And Haggai was involved in the case. And your thoughts on the myelopathy scourge and the lack of recognition of myelopathy will be the main question that I'll direct you on. Are we able to pull up your?
Yeah, it's loading. I apologize for there it is.
So for me, myelopathy, I'll just editorialize whilst Haggai is pulling this up, is one of the most poorly taught conditions that should not be so under-recognized. So Haggai, take it from here.
Yes, so good morning. Thank you for the introduction. I'll try to be fast. This is a 30-year-old patient. He came into the ED just recently, and we were consulted. He came in due to a new weakness. He has long history of alcohol abuse, about 20 drinks a day for the last 20 years at least. He stopped drinking about 6 months ago, so he's kind of trying to change his life. He stopped drinking, he got married, but he has liver cirrhosis, he has pancreas insufficiency, he has kidney failure, and he became acutely weak over the last week, almost bedridden due to lower extremity, both weakness and unsteady gait, and very poor control of mostly his right arm and hand, with some weakness on his left side as well. That's the physical examination from his chart. When I saw him pre-op, he was even weaker, and like he had very poor control of his right hand. He was barely functional, and he was basically bedridden. He couldn't even walk with a walker, and a week before that, he was walking independently. That's the CTE had done over at the ED. We can see advanced degenerative changes with kyphosis and stenosis of his cervical spine. And on the MRI, we can see again severe kyphosis centered around C4-5, severe stenosis C3-4, and core changes going down, even down to C5-6 and C6-7, but not as bad stenosis at the lower levels. So most stenotic levels are C3-4 and C4-5. So just a quick summary, this is a 60-year-old man, significant comorbidities with severe myelopathy, due cervical deformity, and now the question was, do we go all in? Do we try and fix the entire deformity? Do we try to treat his acute symptoms? How big should we go with a pretty sick patient?
So Raj, for me, the big point here is, as identified, myelopathy and the lack of recognition. All of us know about spinal cord injuries and Christopher Reeves, et cetera, and his tragedy, but the fact that people can destroy their spinal cord just through bad habits like alcohol and secondary organ damage seems to be just not recognized. So myelopathy recognition, I know you had a long background in pediatrics, but is this something that's well taught? Can we kind of improve the general awareness of amongst our medical colleagues to better recognize myelopathy?
Yeah. So myelopathy is a condition where the clinical features, the clinical signs and symptoms are very well picked. Even without the imaging, if someone comes on with all these signs and features, we can very well pick it up in the clinic itself, right from all the science we teach in our medical books or examination, like Hoffman sign, clonus, jerk. So if we pick up that very well, we can uh, image them well, we can diagnose them early. And most of the literature is going towards a trend where there is a compressive myelopathy. The best available management option is decompression. And I will be touching on that a little bit later during my talk. But compressive myelopathy, cord signal, I always explain it to my patients this way. If there is a big stone on your neck, or if there is a big stone on your foot, the best way to remove is what? So they will answer themselves that, yeah, by removing the stone. The same way I explain that, yes, your spinal cord is compressed. All it needs is good decompression. And they understand very well. If you make them understand in the simplest language with a good message, they are more likely to undergo the treatment rather than what the information, what the knowledge they had 20, 30, 40 years ago, that cervical spine injury or myelopathy is non-recovering and the surgery won't be successful. So all these conditions, all these points are very important, and the myelopathy is treatable, and we can really give good results with the surgery in these compressive myelopathy patients.
So in the interest of time, Hagai, fast forward what was done and what will have to be done.
Yeah, so we went for the minimal option, and this patient underwent a 2-level ACDF at C3-4 and C4-5, just to try to minimize surgical invasiveness and the perioperative risk. Following surgery, he went back to walking. He regained 99% of his strength back in his right arm and hand. He was very happy. He was actually discharged the day after surgery. Will he be back? Probably, but I don't know. Yeah.
So amazing neurologic recovery from a smaller surgery. Looking at that preoperative CT scan, this is not my patient. Raj, would you suggest that he have a posterior surgery also? I mean, he has severe facet disease. If you look at any corollary scoring systems like the SITE score that I put into the chat, or extrapolate from the trauma literature, this is a 3-column injury, right? So, I mean, this is a highly globally unstable C-spine due to a variety of intrinsic destructive processes. Any thoughts on what will be necessary for this patient, how this patient can be served best now?
Yeah. So sometimes I feel we overthink about sagittal deformity sometimes. And it's not always mandatory to do global in these scenarios. If it was a mechanical instability or a traumatic fracture dislocation or a severely unstable spine, yes, the global instrumentation, global fusion makes a lot of sense. But it's a degenerative condition. With the anterior fusion, the lordosis is achieved with the cages and the plate, and it looks really beautiful. And he's been with that condition for a very long time. And suddenly, with this all debilitating condition, with organ failures, if you try to go global, we will not have the results as good as we think. So he recovered very well. The anterior is serving its purpose. I will just stay with the anterior. But if the scenario was different. If it was significant mechanical instability in terms of the traumatic fracture or dislocations, then I will try to go global 360-degree fusion.
So I personally would have probably gone a little bit lower. I would have not done big interbody grafts, but a 2 or 3 level fixation below would have not added much invasiveness, but would have given me a far better caudal anchoring point rather than these shorter screws. I'm very concerned that this will just basically pivot and avulse through that, what's that, 3, 4 at C5. It'll basically just fall forwards. Alternatively, when the patient's medically stabilized, I'd probably do a C2 to T2 fusion, but those are my thoughts. Only time will tell, but a very dramatic early recovery was cool. Obviously, this patient was a ticking time bomb, and again, great job getting him out of the trouble early on, but I hope that there'll be a lifestyle change, an intervention, and a strong recognition for a possible secondary posterior surgery. This is my thought. Good, thank you. So now, thank you, Raj, for going through our cases, and hopefully it'll serve as some talking points. It's a great pleasure for the first time to have Dr. Raj Sakhrekar here. He is a global spine surgeon, and his training involved Canada, Australia, where he's now practicing in Perth, South Korea, the US in terms of San Diego, Germany, and India in terms of Mumbai. He has already in his short career become a global fixture, and he's the godfather of Ortho TV and Spine TV, and education is his passion. He's published extensively. I think it's about over 100 articles already. And he's also founded the Global Spine Care Foundation. So we all recognize his passion for spine care and popularizing its content to our patients and to our spine surgery community around the world is one of his missions, and he's done a terrific job with this. So it's a great honor to have you here today, and tell us a little bit more about how we can kind of, as spine surgeons, become better at popularizing a message and not just hiding in operating theaters.
Thank you very much. Really great honor and privilege to be coming and speaking on Seattle Spine Foundation. Personally, I'm a big fan of Professor Jens Chapman. Been following him for over years, and it was really a fan moment when I met him a few years ago. And that time we discussed a lot of things, and we discussed a lot of kind of close thought process and all these things. So he invited me for this talk, and I discussed our passions, and I'm here to talk on importance. I'm good to share my screen. Yeah, can you see my screen, everyone?
I love those glasses. Why didn't you wear them today?
Yeah, I broke them.
Oh.
Yeah. So today I'll be talking on involvement of spine surgeons as a drivers of public health and awareness. So I'm currently working in Royal Perth Hospital. It's a tertiary level hospital, as well as as we discussed, privileged and honored and lucky to work in 4 or 5 continents, including Canada, Australia, Germany, South Korea, and India, and other places. It was always my passion to spread the awareness beyond the operating rooms with the help of all the means we have currently with the social media. So just to start with, this is Margaret. She had osteoporotic compression fracture. And to present with, she had back pain and all the symptoms of osteoporosis. But in her 90s, 60s, and 70s, and 80s, and 90s, she heard that spine surgery is a failure. It doesn't work. So she, even if the surgeon's advises to go ahead with the surgery, fix the back, she was not willing for it. Over the period of time, the kyphosis increased, leading to the neurological compression and neurological deficit, and she suffered from paraplegia. Okay, so at that stage, we decompressed her and fused her, but as we know, the spinal cord injuries are irreversible. She already suffered from the non-reversible sequelae of the spinal cord injury at the thoracic level. Another case, this is again 70-year-old lady, some Emma. She had severe lumbar canal stenosis, like pinpoint canal, we call it by Shiza's D. She was told surgery to decompress the canal, but again, she heard in 1980s and 90s, and early 2000 that spine surgery doesn't work and she should try to avoid the surgery. The sequelae of lumbar canal stenosis happened, and she lost the power over the bowel and bladder as well as lower limbs. Another case, Sam is a 54-5 male. He worked lifting heavy weights on his shoulder and neck in a labor driven industry. He developed the neck pain as well as the cervical myelopathy. He, considering the compressive myelopathy, he was advised surgery, but again, same thing, due to lack of awareness, he tried to avoid surgery. Over the period of time, the compression became more and more, the myelopathic changes more became more evident, and he suffered from quadriviruses quadriplegia. So all these things were very well treatable, very well preventable, but only because of the lack of knowledge, lack of awareness. These are just three, not three stories, but across the globe. I have seen it's not just developing countries, but even the developed countries suffer from these scenarios and suffer from this problem. So, as a spine surgeon, it's not our jobs to operate the patients which will come to us in our clinics and operating rooms. It's our social responsibility. It's our big work to do in these scenarios to spread the awareness, to prevent the disease, prevent the treatable conditions which we could avoid, as well as create more and more awareness. To talk about the reach of the social media, this is article from Forbes. It says about 4.9 billion of the people were using social media in 2023, and by 2027 about 5.85 billion out of about 9 billion population will be using the social media. So you understand the magnanimity of it. So why, as a spine surgeon, we are not using the social media to create the awareness? An average person use about 145 minutes every day. What's the purpose we should have? Like, to main purpose I see is to create and spread the information, dispel the misinformation, create and optimize patient to physician interaction, encourage more and more learning with the evidence based studies. These are the mottos we should have to create more awareness and avoid these conditions. A lot of literature has been published which discuss that online studies are more and more effective than the written text for the general population. As we are surgeons, physicians, we are used to read articles, but not much as in the general population. They, in their evening after the post work hours, in their were sitting lazy and watching videos and reels scrolling. If these videos come up about the more education, more information, they have shown to be more retention and found to be more and more effective than just the written text in the books or the article. The scenario is a little bit different in public sector as well as private sector, but still more than 80% of the patients, before they see you in your clinic, they study about you as a doctor, they study the hospital, they follow all the information about their condition, their probable diagnosis. So all these things they search online, they look for you, they look for your hospital, they look for the condition, and all we need to do is create awareness about their condition, what it could prevent, what are the treatment options available, what are the success rates available, what is the post-op recovery is like, how the rehabilitation will work. All these scenarios will reach to this 80% of the patients or general population who's looking for you and your content. We should combat the misinformation. We should facilitate the scientific discussions among colleagues as well as our general patients, and improve the scientific based learning, micro learning through the recent publications and article. As we discussed, the social media currently has a global reach. If I can speak to Dr. Professor Jens Chapman sitting in Australia. The same been seen in North America, in Europe, and in subcontinent Asia, Africa. So it's really has a global reach. What you're talking, what you're making a good sense, what the evidence you're sharing is being spread across the globe. And to be honest, it doesn't cost money. I'm discussing with all you guys. It requires very less of, at least very minimum money. So all these factors considered, we should use the power of social media in healthcare to create the awareness. Again, as per the Forbes article, about 6 billion population will be using it. It's will be the fourth necessity. We call it food, clothing, housing, and the social media and the online education will be the fourth need of the hour, I personally feel. This is a very important article published 2023 in Neurospine by the Hospital for Specialist Surgery. They studied the content, the quality of the content on the social media, and they seen that the layperson have put most of the content about the spine conditions, and the quality of that content is very low. And we as a healthcare professionals in putting these contents are at very low level in terms of ratio by content by the layman versus the professionals. As a spine surgeons, we are way behind with our other colleagues like dermatology or plastic surgery or weight loss physicians or physiotherapists or chiropractors. They are way ahead in creating the knowledge. They're way ahead in putting the good video content and creating awareness and getting spreading all this information to the patients. So we need to kind of build up our game, make ourselves more visible, share this knowledge, and spread it among our colleagues as well as the general population, and share about the modern spine surgery and the success of spine surgery. One small message, this is I always speak and talk about vertebral artery aneurysm, and we see a lot of manipulations been done on the neck, and it vertebral artery aneurysm and manipulation has shown to have devastating complications, right from stroke till paraplegia, quadriplegia, and even deaths. Or you need to create awareness that don't manipulate your back strenuously. If you spread that awareness more and more, the ratio of 1 into 20,000 manipulation and stroke and death will drastically will reduce. This is just preventable thing which we think and could be thing of the future. Again, we need to create more and more awareness about spine health, about the conditions, what are the disease, the signs and the symptoms, what are the imaging options available, what are the treatment options available, how it can be done in more and more better way, and the ways we can prevent this disease, as well as what are the rehabilitation options available for it. So this is about why we make it. Now how we make it, I will talk a little bit. As a professional, we should try to avoid spelling mistake, grammatically incorrect spellings, try to avoid negative words like kill and blood and all these things. Avoid clinical picture which are kind of showing blood or wound. They are kind of flagged by the your algorithms of the social media. There is a lot of music infringement. So if your own original voice is there, that's good. So all these things you should do to create the awareness. Uh, and most importantly, we are doing this not for the likes, not for the comments, not for the views. We are doing this for more and more creating awareness. That should be our motto. That's what I personally feel. So choose your platform based on your audience. If your audience is more of a Instagram based, share more content on Instagram, be more active on Instagram. If your audience is or your patient population is more on Facebook, use more Facebook or YouTube or LinkedIn. LinkedIn is, I personally feel, is for professionals, but still all these platforms are very useful. And depending on your audience, you choose the platform to put the content. Consistency is very important. If you put one content in once in 3 months or 6 months, it won't have as good impact as you if you post consistently, like one post a week or something like that. Always follow ethics, always follow institutional policies, create engaging content. Always there are always challenges. Always try to avoid trolling your colleagues, trolling laymen's or those who are tried creating not so knowledgeable content. Try to avoid trolling them, but create same time good knowledgeable evidence-based content. There is algorithm that it says a longer time duration content, video content won't work. So try to be as short as possible. If less than 90 seconds, that will be good. Maintain professional boundaries whenever you're making content as a healthcare professional. Keep realistic expectations. As I told you earlier, don't go for likes and views. Your main message is to create the awareness. There are also challenges. If you spend a lot of time, you'll feel a little addicted, you'll feel fatigued mentally. Always follow institutional policies, always consent your patients who are giving their permission to spread their patient testimonials. One might give the consent at one stage, but after 4 5 years, they will withdraw the consent. As a physician, it's our responsibility to withdraw the content. But if it's online, it's difficult to withdraw. So always medical legally be clear with the consents before sharing any content online. Always try to improve literacy with various modes of knowledge, like even videos, like podcasts. The Seattle Spine Foundation does webinars, the Ortho TV does, as well as the Spine TV does. All these things are very important. Give very accurate information. Don't give confusing information. Very small, accurate, in small doses information are very well accepted and very well reviewed. There are various guidelines by various uh, societies, what to do, what not to do, do's and don'ts. You can follow them. And this is very interesting from Seattle Spine Foundation itself. I came across few days ago. They seen a question and answer about the cerebrovascular disorder, and with the post webinar, 40% of the physicians said that their thinking ability or their decision making ability post webinars have changed. So that is really making impact that our as a physicians, if any webinar or if Seattle Spine Foundation or Ortho TV or any other educational platform is making a decision making practice changing guidelines and influencing them, that's a real win-win for me and for every one of us if we create that kind of awareness for the physicians and in terms of in future for the general population. And as you are, if you want to grow, there should be always, we'll go above and beyond with the networking and collaboration, and all these things will help in our research dissemination, spreading the knowledge, and it will spark the discussions. Again, these are few guidelines by various societies, NAS or American Pain Society, or all these societies. They discuss about spreading the knowledge, how to do it. So as a spine surgeon, it's very important for us to have a pre-op planning, intra-op planning, and how to follow up the post-ops. Creating content is the same. We should have a very good script. We should have minimal words. We should have good thought process, what message we want to give. Interrupt the sound and the lights work is very, very important. Good sound, good lights are key for the success and spreading the knowledge. And once it's ready, when should you release it? I personally feel the release time should be when you are most active. It's not morning, it's not afternoon, it's not evening. The most important time for the release, where 1 or 2 hours you are active and you have the maximum engagement, that should be the time of the release. And the more you engage with your audience, the more response you will get, the more algorithm will choose you to spread the knowledge. So within 1 or 2 hours of the release, that should be the maximum engagement you should have. Short 60 seconds, no kind of professional language, simple words, simple language should be important. There should be hook, there should be call to action, and at the end, in that 60 to 90 seconds, you should have a conclusive message. Okay, this is to be done, and this is should be understandable to all the general population. No need to show all your whole body. Even just the face and shoulders is more than enough. Most of the people, they don't play the sounds, they use the just follow the caption. If you're putting a video, always have a caption. Those who are not using the audio can read the caption and get the message. Lights and sound we discussed already. And if it doesn't, as I told you, it doesn't need much money, it doesn't need cost. All I use is the edit app from Instagram. There are various apps available, paid, they are paid, unpaid. The edit app in Instagram is free. It's very simple app. I create the videos. Like I was very fortunate and lucky to be part of the social media committee of the Sclerosis Society, as well as I have volunteered for AO Spine, Spine Society Australia, as well as Society for the Neurology of Spine Surgery, Association of Spine Surgeons of India. So all these societies, I work closely to create more awareness. So what I do is put the video, record the video, put it online. Before put it online, put it in the edit app, put the topic of discussion, put the captions, and with the best audio, best captions, I put that on the social media. Again, once this is done, I also put a lot of related topics which are discussed, current trends about not to manipulate your neck, not to get hammered on the neck unnecessarily. If there is any event going on, ice hockey match or cricket match, and someone gets injured, I just not the discussing about the player or the sportsman, but about the injury, how this happens, how it could be preventable, what are the management options. So staying current to the trends, all these things are which are we can do, so that the awareness could be spread about these conditions. And to coming into the last part of the discussion and the talk, AI is definitely coming in every field, and not just in social media. With the artificial intelligence, we can create more and more high quality content, spread more awareness. The augmented realities for patient education, the surgical cadavers, and all these things will come in picture, and that will definitely help for the patient education. As a global surgeon, as well as being involved with various societies, I feel there is a huge vacuum we have to fill, the huge void we have to fill. uh, and we as a spine surgeons come together and create campaign about creating more and more awareness about the spine ailments and spine pathologies that will prevent the disease and overall burden of the healthcare system of the spine ailments and spine pathologies. So just to close on, I always believe as spine surgeons, we should heal beyond the operating room and our clinics with the knowledge, with the compassion, and with the communication. And if we don't tell our story, someone else will, and their story may be wrong. So with that, I will conclude my talk. This is my Instagram account, and we are more than happy to collaborate with Spine TV, Ortho TV in future, and looking forward for more and more collaborations with Seattle Spine Foundation. I really thank Professor Jens Chapman for giving this wonderful opportunity. Thank you so much.
Thank you, Dr. Sakhrekar. Great job, again, identifying some of the key messages, providing tangent, practical points, and just a big picture perspective, literally a global vision. So congratulations on that. Just a quick question. So how can we, in this short attention span, ADHD world, compete with like chiropractors who show sometimes, just like what you have shown there quickly, they have some dramatic videos where they do some unspeakable things to human beings with their spines. How can we compete with that? I know we do some pretty amazing things in the OR, but these are like multi-hour endeavors, and the x-rays don't mean much to the population. So how can we compete with the shock value in a TikTok 60-second world?
Yeah, so like we We, as a spine surgeon, love the attention to the details, like very much details. But that's what not general population might like. The attention span is so small. So there is something called hook, where you need to get the attention of the general population in that first 3 to 7 seconds itself. And in that hook, maybe ask a question like, do you know what do you want to know? Do you know this? All this in 3 to 6 seconds, create a hook. Like, do you know patient how this patient got stroke? Do you know how what is ankylosing spondylitis? Do you know what is lumbar canal stenosis? Do you know? So that's called creating the hook. And once you create the hook, the audience will get hooked, and then you create the awareness message. What are the things? And after talking about 45 or 30, 40 seconds in that small message in one liner, simple language, you last 15 to 20 seconds, you keep it to tell the conclusive message, that call for action, we call it, that this should be done about this condition. If just to give an example, if we are talking about the most common condition, the lumbar stenosis, will ask, are you suffering from leg pain, claudication, or difficulty in walking long distances? That's the hook. Then you talk about what is lumbar stenosis, all the signs, symptoms, or what are the investigations to be done. That will take 20, 30, 40 seconds. And we tell in third part, what are the treatment options available for it, and what whom you should visit, all these things. So all we can do in a little bit of 60 to 90 seconds. It's a little difficult, but you'll get, as we know, when we start operating a micro disc, first time it will take about 2 hours. When we operate more and more, at the end of the 1 year or 2 year, you will operate in like 20, 30 minutes. In the same way, I feel the social media handling will be, when you start making this content and things, it will be longer videos, but the way you handle it, the way you more get experience to it, you will make a shorter and more commanding and understandable content, I feel.
Then a final question I'm going to have to stop is ethics. So you brought up ethics. Patient testimonials are widely used. They can be readily abused. You can have horrible disasters, and that one great, glorious case that turned out well in a good-looking patient somehow ends up on social media. What are the ethics about patient testimonials? What do you think about them? And where are boundaries? How can we use them in an efficient but also above board fashion?
Yeah, so again, every board, whether it's uh, practicing policies in Canada, or institutional policies in Canada or North America, US or Australia, they vary very, very, very differently. But having a confidence of the patient is the most important. Only if the patient agrees and they want to do it with the full consent, then only you should go ahead. Otherwise, sometimes we had a scenario where parents gave a consent for putting a content on the social media when the kid with the scoliosis was 14 years, but when the kid grew up about 18, 19 years, they were not comfortable content on the social media. Even if we were legally safe, as a responsible physician and surgeon, we have to accept the request of the patient and get down the content from the social media, take down this content. Even though once it's put, it's difficult to take it out from everywhere. Some places it will be still there, but these policies, this confidentiality, the consents are very, very important, and we have to respect the institutional policies, the patient policies, as well as your medical board policies. And of all, the most important is the policy, the consent, and the confidentiality of the patient. That's what I think.
Well, we'll have to end here. We certainly enjoyed seeing you, hearing from you, hearing your thoughts. You've done an amazing job as a young surgeon, just going into the new frontier. I know tomorrow has arrived. It's now officially, I think, February 19th for you, so it's after midnight. But thank you so much for taking the time to educate us and sharing your thoughts and vision with us. And hopefully we'll have many occasions to celebrate and exchange our ideas in the future. So thanks so much, Raj.
Thank you, Dr. Chapman. Thank you.